All right, good morning, guys. This is going to be the medical lecture for your EMT Bridge. I have it labeled as part one, but I think I'm going to do the whole thing all in one big recording. So what we're going to cover is medical terms. There's going to be a bunch of them. I'm going to just breeze through them. You can watch this video again. There's also a reading that has each of these medical terms. We're going to cover a bunch of medical diseases you must know. You must know what these are, how we can treat it. Some of them we just can't treat. We just have to recognize. We're going to cover a little bit of transport positions and medications and pharmacology, basically how we're going to treat these medical conditions. So, medical terms, a bunch of them. So acidosis, your heart attack, acute coronary syndrome is a must. This you will see on your test several times. ACS, it's basically a range of symptoms and conditions related to acute being sudden or new, coronary being the vessels that surround the heart, and syndrome being, I don't know what it is. You have to figure it out. You'll see different things on there. It'll come up later as we go through the medical conditions. Cardiogenic shock, we talked a little bit about shock already. Congestive heart failure, different COPD, which you'll cover in your respiratory. The different types of diabetes. We cover a little bit about the diabetes when we covered oral glucose. Diaphoresis, we've mentioned this several times with the abnormal sweating. See, embolism is a clot, but it's not necessarily like a blood clot, and you'll see this later. Insulin, it's what we need to basically use the sugar. You need to know the difference between infarction and ischemia. Myocardium, anything that says myo is going to be muscle. Necrosis is actual death of tissue. Let's see, paresis, that's going to be your paralysis or weakness. So this will come into play with your stroke patients. Here's your polydipsia, polyphagia, polyuria. Those are key for your diabetic type 1 hyperglycemic. Rales, bronchi, stridor, different lung sounds, different sounds that you can hear, determine what's wrong with the patient. Let's see. Thrombus, so that's more of a blood clot. Thrombolysis, anytime you see lysis, it's a breakdown. And TIA is kind of like a mini stroke. It's a stroke that goes away after a while, within 24 hours. Tidal volume, you'll get that with your respiratory. It's going to be the amount moved all the way in and all the way out. Let's see. All right, so medical diseases you must know. We're going to go over that acute coronary syndrome. Huge. You see how it covers angina, myocardial infarction, ischemia, and costochondritis. You can have congestive heart failure. There's a bunch of things that can be under that acute coronary syndrome, but we'll go into them more specific. So angina is a fancy way to say some chest pain. You'll hear different presentations if you watch on YouTube. We'll call it angina, which is weird. You can have stable angina and you can have unstable angina. Basically, if the person's blood pressure's normal, if they're able to get the pain to go away after rest or some nitro, then that's considered stable angina. And people can have stable angina for years. They don't quite have enough of a block to qualify for a surgery. So if a patient has stable angina, they take their nitro, they don't want to go to the hospital anymore. We're like, okay, well, we think you should go, but you're able to refuse. And then the unstable angina, we really need to push these people like, hey, it's not getting any better. This is different than the last time you had your angina. These people are going to be, sorry, keep yawning. These people are going to be prescribed nitroglycerin, which is one of the medications you're going to be able to give as long as it is prescribed to them. Acute coronary syndrome, just a blanket term for acute, sudden, or new. We don't know what it is. It's some sort of pain or discomfort. We haven't ruled it out as a heart attack yet. It could be just an angina. It could be a couple other things. So acute coronary syndrome, if you see this, we are going to treat it as if it is a heart attack, but they are not the same thing. ACS is not a heart attack, but a heart attack is included in ACS. So here's your heart attack, your acute myocardial, so sudden or new, myo being muscle, cardial being your cardiac muscle, infarction being like damage to the tissue. You can see on the picture there's a block in the artery, the coronary artery of the heart, and that tissue is starting to get damaged and it starts to die. So that is an acute MI or acute myocardial infarction, and you're going to hear people talk about STEMIs, which is reading an EKG. It's an ST elevation. So one of those squiggly lines is ST and it's elevated, so ST elevation. And then MI being myocardial infarction. So we pronounce it as STEMI. Congestive heart failure, talked a little bit about this when we were talking about JVD. So congestive heart failure, your heart's basically either becoming too weak or it can't fill up enough. Remember I was saying like you work out a lot and you build muscle, the muscle gets bigger. But with the heart, you can see the picture there, the thickening of the muscle actually makes it to where there's not enough room for enough blood to be able to be ejected out, or it's too thick and stiff to really get the blood flowing. So you can see right-sided heart failure, blood's not able to get it into your lungs to get oxygenated. So it's starting to like back up. It's not getting enough oxygenated blood into the rest of the heart and the rest of the body. The left-sided heart failure, it might not be able to get it out of the lungs, which means it's going to back up into the lungs, and it might not be able to get it through the rest of the body. So that's kind of an idea of the difference between your left-sided heart failure and your right-sided heart failure. Your aortic dissection versus your aneurysm. So an aneurysm is kind of like a big balloon that hasn't burst yet. It could absolutely burst at any moment. So hitting bumps, pushing a bunch on their belly. And then the dissection is kind of like a bulge, but it's between the layers of the muscles of the artery. So they're kind of similar, but it's almost like if you could take a balloon and separate one layer of the rubber and another layer of the rubber, or if you had two balloons inside one another, that's going to be your dissection. Either one of them can burst, and these people will bleed very quickly. We talked a little bit about a AAA, which is an abdominal aortic aneurysm. So you can see on the picture there, the line is your diaphragm. So your thoracic is the upper area of your aorta. The abdominal is below the diaphragm. So you can see how it's abdominal, and then it's an aorta, and then it's either going to be aneurysm or a dissection. So that's what that AAA is, right in the middle and the bottom. Abdominal aortic aneurysm. You can also have a thoracic aortic aneurysm. What's nice about that is you've got your ribs and everything kind of protecting it. With your abdominal aortic aneurysm, you can sit differently, you can get hit in the gut, there's all sorts of things that can trigger that rupture. So if you are palpating somebody's belly and you feel a pulsating mass, get off of it and get them to the hospital. Assume the worst, assume that it is a AAA. Pericardial and myocardial diseases. So if you look at the different layers of the heart, your myocardium, muscle, myo, pericardy, so anything that's peri is going to be surrounding, endo is within or inside of. So the next few slides are going to kind of cover different pericardial and myocardial diseases that can also be under the umbrella of the acute coronary syndrome. So pericardium, you can have the fluid around the heart, so peri around cardium. You can have it fill up with blood or air. What that's going to do is it's going to compress the heart, so it's not able to move blood as needed. It can also have a bunch of blood there, so everywhere else in the body is now lacking blood. So this is a massive emergency. So shortness of breath, you get clear lung sounds, there's recent trauma to the chest, flat neck veins. They may have fluid or blood around the pericardium. If you have JVD, it may be air. It could be blood and fluid, but there also may be air in there, and that's what's causing that fluid to go back up. So that distension of the jugular veins. So muffled heart tones. You guys won't be doing a whole lot of heart tones, but you can see there on that bottom left corner, low blood pressure, they're cruddy blood pressure, they can't get any fluid to move around, so it's going to sit in their jugular vein, it can sit in their feet, and this is going to be more of a sudden kind of thing. Pericardial effusion, that's essentially just that fluid building up over time. It can turn into a pericardial tamponade, which when we looked at our tension pneumo versus like a simple pneumo, it starts out as simple and then gets worse and turns into a tension pneumo. So pericardial effusion can start out slow and then become a pericardial tamponade. So here's another slide over the effusion, just the buildup of extra fluid around the heart. And then you can see the picture on there, the tamponade. Every time they like inhale and exhale, you can feel different changes in their blood pressure, because when they inhale, the lungs are going to expand, it's going to put pressure on the heart, so their blood pressure is going to be like lower. You won't feel it as well. And we call that pulsus paradoxus. So every time that they breathe in, it helps, or it decreases the amount of force the heart's going to have to push it through the rest of the body. So another picture of your pericardial tamponade. You can see there the effusion, it's starting to surround, and then it actually gets bad enough that it surrounds and puts pressure on the heart. Jugular venous distension, blood is unable to flow as it should. It is not leaving the jugular vein and going into the heart as it needs to be. It's a sign of heart failure, which is typically going to be your right-sided heart failure, but it's also a sign of your pneumothorax, your like tension pneumo or your simple pneumo. All right, so that is a lot of the cardiac medical conditions. There's additional reading if you watch this presentation, or if you look at the PowerPoint presentation, you can go over all the notes that are in it. And then there is a reading material that's also attached to this. So we're going to cover respiratory. I know that my brother's going to cover respiratory on a different presentation. Yeah, but this one's going to cover all the ifs, ands, and buts you might need for the test. So, asthma, reactive airway disease. Something has triggered a reaction. What it's going to do is your bronchioles are going to tighten. They're going to constrict. They're going to you can see on the picture there, the wall's inflamed, it thickens, it traps air into the alveoli. A lot of times when you ask a patient that's having an asthma attack, they describe it more as they can breathe in, but they feel like they can't breathe out. And that's what's happening, is air is being trapped in the alveoli, or the little air sacs. COPD, chronic obstructive pulmonary disease. Sometimes asthma is thrown in there because it is chronic and it is obstructive, but most of the time when we're talking about COPD, it's going to be more of a worsening medical condition. A lot of times with asthma, it doesn't get worse and worse and worse over the years. Sometimes people grow out of it. But with chronic bronchitis and emphysema, it's not going to get better. It's going to be something that they live with or they die of. So your chronic bronchitis, it's very similar to your asthmatic, but there isn't as much of a trigger. So the asthmatic, they'll be fine. Then they have a trigger and their airway reacts and they can't breathe. The chronic bronchitis, it's always a little bit inflamed. They always have excess mucus. So what's happening is air is being trapped all the time in the alveoli. It's not able to move in and out as it should. So these people are chronically not getting enough oxygen. These are the people you're going to see on oxygen at home, those oxygen concentrators and stuff. With emphysema, this is highly related to smokers and inhaling toxic substances, and it has a breakdown of the alveoli. So the alveoli sacs themselves cannot hold and stretch and move, but instead they're just like these giant overinflated balloons that don't have any give or stretch or pressure anymore. So what that causes is a hypoxic drive. What happens with when we stop breathing, we get a increase of CO2 in our body, and our body does not have enough oxygenation going to our brain, and what we do is we start to breathe. That's what's actually triggering our breathing in. With COPD, remember, they've got air, they've got stuff like trapped in the alveoli. They're not able to get all of that out of their body. So instead of having that, oh, I don't have enough oxygen, I need to breathe, what it is they have too much CO2 built up, and that's what's triggering them to breathe. And so you have somebody that is on oxygen all the time, their SpO2 is low, they have a history of COPD, and we give them too much oxygen. So let's say we put them on a non-rebreather. They will actually lose that drive of wanting to breathe because they don't have enough of that CO2 built up. And so we do have to be mindful that if we do give them too much oxygen, we may have to ventilate them or breathe for them. So that's like the big kicker there, is you never ever withhold oxygen from someone, but be mindful that a COPD patient may not need to be at 95, 96, 97% SpO2. You want them to their like normal. So if they're normally at 92, 93% is perfectly normal for them when we treat them. Pulmonary embolism, think of it as a lung attack. So just like the heart attack, except instead of coronary arteries, it's the pulmonary blood vessels, and it ends up having a clot in there that blocks it. So you can see on the picture there, there's a clot, and all of the tissue that is distal from that clot is not being oxygenated, and it's going to have dead tissue. So these people are going to have shortness of breath. You're going to hear lung sounds. Lung sounds are going to be fine. What you have to do is go off of history. What caused this clot? What caused this clot to break loose of wherever it was and flow into their lungs? So people that are on an airplane with their legs bent, with that kind of bending of blood vessels, you can develop a clot. And when you start walking around at the airport again, that clot breaks loose and flows around, goes up into the right atria, goes into the lung, goes to get oxygenated, and bam, blocks. So go off the history, any recent travel. You'll see commercials, and it's actually kind of a high statistic. Women that are on birth control and smoke have a higher tendency to have a pulmonary embolism. So getting that history. Remember, birth control is a medication. Pneumonia, this is your infection, either bacteria, virus, fungus. They got some water and nastiness in their lungs. They inhaled it. It can be very life-threatening, but it can be something super simple that they can get over. It's particularly life-threatening to our infants, children, and people over 65. So the sound you're going to hear with this is that bronchi, that thick, nasty milkshake bubbles. Pneumothorax, we talked a little bit about pneumothorax. One of the things I didn't really mention before was subcutaneous emphysema. So where it actually leaks out of the thoracic cavity and air goes in between the layers of like the skin. You can actually see this go up into their face and around their eyes and be all puffy. But you can also feel this if you feel underneath like at their collarbone, and it feels kind of like the packaging little bubble wrap, that's going to be your subcutaneous emphysema. It is actually leaking out of the thoracic cavity and under the skin tissues. Pretty neat. Altered mental status. So we're going to cover some endocrine disorders, seizure, syncope, poisoning overdose toxins, even though there's more information on poisoning overdose toxins on a different slide that I have, or a different presentation. So endocrine disorders. The big ones that kill people, we're going to talk about thyroid storm, myxedemia coma, adrenal problems, and diabetes. So your endocrine system is awesome. It's either like on or off. There is no like reverse. The same gland doesn't like have the antidote for it. So like the adrenal gland will release adrenaline, but it's not going to release anything that is like opposite of that. Your thyroid gland will release your thyroid hormone, but it won't release like anything opposite of that. Your parathyroid, what it's kind of in control of is your calcium levels. And so with endocrine, it's either like on or off, and they do not fix themselves very well. They're incredibly strong, but if they get sick or they get damaged, they cannot fix themselves, they cannot heal. And we have a really hard time with actually replacing them. We cannot replace the pancreas. Yes, we can do kidney replacement surgeries and liver and stuff, but when it comes to your thyroid, like people have to be on medications for the rest of their life. And it's just one of those, we have a hard time replacing endocrine systems. So thyroid storm, this is when they have hyperthyroid. There is too much of the thyroid hormone going around. What your thyroid is actually in charge of is your metabolism. How well you break down food, your sleep-wake cycle, your energy, your running, your temperature regulation, a lot with metabolism. So the more of the thyroid hormone, the more activity. Remember, it's either on or off. So it's push, 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 go, go, go. And this disease is actually called Graves' disease. If you ever want to remember the symptoms of Graves' disease, just think you run yourself to the grave. Everything's going to be hyperactive. They have heat intolerance because they're always like running hot. So if they go outside on a really hot day, they can actually go into like more of a failure, go into tachycardia, go into arrest because they get too hot too easily. They already run a little high. High blood pressure. They usually have higher heart rates, more amped. They're thin. They are just tremors and stuff all the time. Diarrhea and vomiting. It's because things move much quicker. So instead of sitting in their gut and absorbing appropriately, it's going through. They're also burning a lot of energy, and they're not having time to absorb, so they may have low glucose levels. So thyroid storm is when you start having all of this, and delirium, altered level of consciousness. They're pumping so quickly with so much dehydration they can go into congestive heart failure. We need to fix this as soon as we can, and at the EMT1 level, we need to treat for shock, kind of go opposite of what they have. So keeping them calm, don't overheat them, give them some oxygen, give them sugar if they need it, and transport to the hospital where they can be given fluids and medications. So thyroid storm, run yourself to the grave. This is the opposite of that. So it's either on or off, remember? So it's either push, push, push of the thyroid hormone, or it doesn't push it. So again, this is metabolism. This is more common than your hyperthyroid, and this is actually more common in women than it is men. So overweight, hair loss, puffy face, bradycardic, things are not going, they're not moving much, so instead of the diarrhea, we get constipation. They're bradycardic, low blood pressures. They already run a little colder, so they really do not like to be cold. And what we want to do is we want to keep them warm, we want to treat for shock, and we want to get them somewhere where they can be be medicated appropriately. Adrenal crisis. So you've got your too much adrenal and not enough adrenal. This is going to be not just our metabolism, but because your cortisol is a steroid, when you have too much of a steroid, you're going to see on here how steroids affect your sugar. But your adrenal glands are actually the ones that push epinephrine or adrenaline through our body. So symptoms can vary whether it's Addison's disease or Cushing's disease. So Addison's disease, this is what they actually believed that JFK had. So if he did, they believe if he would have survived the gunshot wound, he probably would have died later, because they have so much like adrenaline running through their body all the time. So what happens is they actually are unable to counter any significant stress. So once they do get stressed, they're not able to manage that, and they will kind of collapse. They go into a shutdown because they're already amped up so much that the adrenal glands really can't do anymore. And one of the theories behind why they think he had that is because he did have that kind of bronzing of his skin. So they believe that he wouldn't have been able to handle the hypovolemic shock, or like the shock that would have come from the gunshot wound anyways. Cushing syndrome, think cushy tushies. These are going to be more overweight. They are going to have a lot more sugar, so hyperglycemia. They have that, like, they talk about like a moon face. So this is too much cortisol. And now you're going to go, oh, I remember seeing commercials on like cortisol and belly fat. Well, think of it like that. Belly fat, cortisol, and they go together. The more of a steroid, the more sugar is retaining. The adrenaline is, so cortisol is a steroid. And then you've got, let's see, you're going to find, so males, they'll have gynecomastia, so like having boobs. You're going to have fat deposits, a buffalo hump, so a weird hump on the back of your neck. With all that extra sugar, all that extra weight, you're going to have damage to your bones. With women, they may end up not having like normal period cycles, and they'll have like weird facial hair and beard and all that kind of stuff. So little cushy tushy there, angry, overweight, a lot of fluid person versus the Addison's disease, which is just they're running rampant all the time, and they really can't handle any additional stress. The last of the endocrine ones I'm going to talk about is your diabetes. So type 1 diabetes, that's your insulin dependent diabetic. They do not make the insulin needed for glucose absorption. So they need to be on insulin, either injection or a pump. Your type 2 diabetics, they may not utilize the insulin as needed. It's more common for this type of diabetes because, well, especially here in America, we're a bunch of fat. We love our sugar, Americans. So the type 2 diabetics, at first you can control it with diet, exercise, and if you can't, then you end up having to take insulin if needed. Hypo versus hyperglycemia. Hypoglycemia is typically quick. It's within like the last couple hours. Sometimes in the last 20 minutes, they're going to be pale and hungry and tired and go into seizure, but it's different. It looks a little different. With your hyper, it could be over days. They're not going to be all that pale and sweaty. They're going to be thirsty. They're going to be hungry. They're going to pee all the time. So polydipsia, polyuria, polyphagia, as I was talking about earlier. So hyperglycemic, but they may have that unconscious, unresponsive. And if it gets bad enough and they're type 1 diabetic, it actually turns into diabetic ketoacidosis. So initial warning signs, dry mouth, think sugar, that spiked in blood sugar, if you don't have the ability to get a blood sugar, go off the history. They're drinking a lot, they're eating a lot. And instead of their body utilizing the sugar, what it's doing is it's breaking down muscle and fat, and then that releases acids. So too much acid in the body can actually cause changes in your respiratory rate. It'll cause changes in your mentation. These people are going to have an extremely high blood sugar. They may have seizure activity. They're going to be unconscious and unresponsive, and they're going to be breathing very deep and very fast. So we call that Kussmaul respirations. So Google that one up. Seizures, it's basically an electrical storm in the body. Most of the time, 30 seconds to 2 minutes. Tonic is the actual like stiffening and holding of the muscle. So the opposite of that, atonic, would be relaxed. Clonic is going to be the periods of shaking or jerking. So myoclonic, that is short jerking of the muscle. Clonic is just periods, the whole period that it was shaking and jerking. So somebody has tonic clonic, it's going to be like flexing and holding, and then like that pattern, flex, hold, flex, hold, flex, hold. Opposite of the movies. So in the movies, they show people like flailing all about. With seizures, think like if there is an electrical impulse, everything's going to be tightening at once. You don't see the left arm flailing at this pattern and the right leg shaking at this pattern. It's going to be very close, if not the identical times. Status epilepticus is a massively horrible true emergency, and we have a hard time stopping it. Unless you have anti-seizure medications, you basically just try to keep their airway open, putting blow-by oxygen on, suctioning if you need to as best as you can, keeping them safe so there's no additional trauma. Try to keep them cool, don't let them overheat. You could assess their glucose levels because what they're doing is they're burning up energy. Stroke, talked a little bit about this with Oren on his presentation on neurological emergencies. There's the biggest difference is you're either going to have a clot or you're going to have a bleed. And since we clinically cannot differentiate the clot versus the bleed, this is when you cannot give aspirin. You would think like, oh, a clot, we want to give some aspirin, but you don't know if it's a bleed. And so if they have stroke-like symptoms, more often than not, it's going to be a clot because, again, we're fat, overweight, high lipids, just don't care for our bodies kind of people, as opposed to trauma, which is typically what causes your bleed. But you can't go off of what most of, and you can't go off of that. You have to just be like, it's a stroke, I don't know what it is, no aspirin. All right, transporting our patients. You guys need to know kind of the names of the different positions that will transport people. So Fowlers and semi-Fowlers. This is the most common how we transport them in the back of an ambulance on the gurney. Semi-Fowlers, just kind of up at a 45-degree angle or so. High Fowlers, they're going to be sitting up a little more. What's great about Fowler's position is it's beneficial for just position of comfort. You have enough weight off of your chest that you can breathe appropriately. It's not too high up to where you get a bend in like a natural area of the spine to where it can cause like back pain. These are typically the most common forms of transportation. Your Trendelenburg. So I wouldn't do like an extreme Trendelenburg. Just a very, very, like that Trendelenburg position on the top. I probably wouldn't even go at that angle, but that's going to be like you're treating for shock. The reverse Trendelenburg, the biggest thing you need to watch out for is having pressure on the feet, and it can have, if their ankle is like moved a different way or something, they can actually have trauma and damage to the knee. But you kind of want to put them in either a flat or a reverse Trendelenburg if you're expecting or suspecting a traumatic brain injury with brain swelling. Prone and supine. So supine has up, prone has on. Typically, we don't transport people prone. It was actually really common for people to be admitted in the prone position when they were in ICU during COVID, but typically we don't transport a whole lot of that. Only if we have, like if we're examining, and then prolonged periods of time so it can prevent a pressure sore. The dorsal recumbent, so they're on their back, but their legs are up. We typically don't do that unless we're doing birth, which you guys are going to cover on the weekend. And then, of course, your supine, just flat on their back, transporting them unconscious and responsive. You can do vital signs that way, position of comfort. Maybe they just want to lay back. Lateral versus Sims. So you can see in that top one, they are on their right lateral. So whatever they are on that side. With the Sims, you can see how the arm is actually in the reverse and you're using pillows and stuff to maintain that sideways. But the Sims position, arm is kind of out the back as opposed to the lateral position or the recovery position. Putting both of their arms forward and using their arm to kind of keep their airway open. Let's see. All right, medications. Guys, got to know these. I know I've covered them before. You guys are gonna rock this. All right. So medications, you need to know the mechanism of action, basically how it works, indications, contraindications, the dose, the route, the time, and how do you document it. So these are your rights. When you do your medical assessment, you have your medical patient, and they tell you I've got shortness of breath. Okay, well, I need to know what medication is for this patient. So depending on the indication, what it is, okay, they've taken this drug, so I can't give it. That's going to be your contraindication. The route, is it inhaled? Do I inject it? Is it absorbed through the skin? Does it absorb through the mucous membranes? Or do they eat it or ingest it? Right time, that's kind of medication specific. And you also need to make sure that it's a not expired medication. And then your right documentation, you gotta put the dose, the route, and the actual like name or abbreviation. Don't be making stuff up. There's approved ones. So nitroglycerin, we're gonna give it for our ACS patients. What it does is it's a vasodilator. It's going to reduce the workload of the heart and open up those blood vessels. So the heart tissue can actually start receiving blood and oxygen again, because if you revert back to the acute myocardial infarction, you can see that the clot has completely occluded to where there's nothing going around that clot. But if your blood vessels get bigger, then there's actually room around the clot. And so that's kind of our goal with the nitroglycerin. So we give it for ACS. Remember, I'm not saying for myocardial infarction, I'm saying for ACS. Because we don't know if they're having a heart attack, but they're having some chest pain. We don't know what it is. It has to do with the heart. So we're going to give the nitroglycerin. They have to have a decent blood pressure. So I definitely think 110 is even a little low. I like 120 or higher. But the book answer, 100 systolic, it needs to be over 100. No Viagra, Revatio, Levitra for 24 hours, and Cialis for 48 hours. I covered the phosphodiesterase inhibitors. They're unpredictable when they will cause vasodilation. That was their original response, was supposed to be for blood pressure, but it ended up causing men to have an erection, so they actually changed the medication instead of being a blood pressure med to an ED med. The max dose is 3 sprays or 3 tablets, and that includes the patient dose. So if they give themselves 2 doses of nitro, that means we can only have the 1 dose left. It does absorb through the skin. There's actually nitro paste that is like, well, paste that they put on the skin, and then they cover it with an occlusive dressing. So if you're touching the tablet or you get the spray on your skin, it can actually absorb. And then you also are going to have the hypotensive effects of the nitro, so the dilating of the blood vessels. That dilation can cause anxiety and some tremors. It's going to cause a wicked headache. It can cause some tachycardia because your blood pressure is going to go down, so your heart rate might go up. It may make you dizzy because your blood pressure may drop. You may feel faint or even pass out. That syncope is basically a significant drop in blood pressure to where you faint, and it can cause hypotension. Well, lack of blood pressure. We want to give it sublingual or SL. It is 0.004 milligrams, either a tablet or a spray. That there is the spray bottle. There's 200 sprays in there, 0.04 milligrams or 400 micrograms. What we do is we assist the patient in taking it. So we put it in their hand and they put it underneath their tongue for the tablet, or they lift their tongue up and we squirt it underneath their tongue. We have to get a blood pressure before and after, and we want to make sure that we assess their pain because we want their pain to decrease to a 0. A pain of 0 is awesome. So aspirin, we're also going to give this for our ACS patients. What it is an antiplatelet aggregate. It makes the platelets slickery. It makes them less likely to clot. This allows the clot causing chest pain. Oh yeah, the clot that causes the chest pain, it makes it so it doesn't get any bigger. I don't like the way I wrote that. It sounds stupid. So we give it for ACS chest pain. They cannot have an allergy to aspirin. We don't want any recent bleeding or potential for bleeding. So recent surgeries, GI bleed, because this is going to make it to where any clots that they do have don't get any bigger. We don't want them to be bleeding everywhere. Thus, why we also don't give it for our stroke patients. It's given PO or oral. It's basically in multiples of 81 milligrams. A lot of times our elderly, it used to be everybody got 162 milligrams, and they're realizing that it can be a higher dose. But our elderly may not be able to metabolize it as effectively. So 162 milligrams is safe for our elderly patients, 324 milligrams for the adults. If their med is a 325, that's when you're going to get your 325 milligrams. I said this earlier in the other class that we had, that math 81, 162, 324 does not add up to 325. But you do want them to chew it up. What it does is it's going to start to absorb in the mucous membrane, similar to our oral glucose, similar to our nitroglycerin, before they swallow it. Swallowing it into the stomach, it takes the longest, 15 minutes before it really starts to break down. Our epinephrine, it is a beta-2 agonist as well as beta-1 agonist. The beta-2 is what opens up the airways. It's a sympathetic drug, so you see the mimetic like mimics, and sympatho being the sympathetic, fight or flight. Sympathetic is your fight or flight. Opening up the airways constricts the blood vessels. We don't want a bunch of fluid leaking into the area. That fluid leaking when they're having an anaphylactic reaction is the swelling of their tongue and the swelling of their lips and everything. We don't want that. So we're going to constrict those blood vessels. And since it's a beta-1, it's also going to increase heart rate. With the constriction of the blood vessels, it's going to make it to where blood pressure is going to go up. But our main thing is that beta-2, we want those airways to open up. We want them to breathe. When we give it at the EMT1 level, you guys are going to give it for anaphylactic shock. So our severe allergies, that swelling of the airway, the inability to breathe. And you're also going to be able to prepare it for CPR or cardiac arrest. For contraindications, they're kind of relative. If you give somebody that has a really, really weak heart, epi, it could make them go into cardiac arrest, and then you got to give them epi anyways. Or if they have high blood pressure, we want to be mindful because we're going to make their blood pressure go up. But if they are in true anaphylaxis or in cardiac arrest, we're going to be giving epi. So side effects, anxiety, tremors, headache, everything is going to be going fast, may not be able to sleep, some chest pain, and they may go into cardiac arrest. So the 1 to 1,000, this is a stronger concentration of it. We're going to give it IM. So if you think of I am alive, this is the person that has anaphylaxis. 0.3 milligrams is the adult dose. That's what's actually in the EpiPen auto-injector. For the pediatric, you can get an EpiPen Junior, and it's going to have 0.15 milligrams dose. But you saw when we were looking at the Epi in class with the ampule, that's that scored weird shaping glass thing you gotta break. You may have to draw it up. So if you read on there, it says 1 to 1,000, you know the concentration. You know that it's like 1 milligram per 1 milliliter. So if you're going to draw 0.3, you need to have 0.3 milliliters. And we practiced that a little bit in class. For the cardiac arrest, since it's going IV, so I am alive and I've arrested. So IV, they have arrested. That means cardiac arrest, that's CPR. You're going to prepare that. That is 1 milligram of 1 to 10,000. You're going to prepare that for the ALS provider to use via IV. Mechanism of action for albuterol. So kind of similar to the Epi, not as potent, and it doesn't have as many beta 1 or the heart. So beta 2, you have 2 lungs, beta 1, you have 1 heart. We want it to open up the bronchioles. We want it to open up that airway. It also is a sympathetic fight or flight medication. That's kind of how it works. We can give it for anaphylaxis as long as it's not anaphylactic shock. Or anaphylactic shock, we want to give Epi first. But anaphylaxis and they're not shocky, or we've given them their Epi and we want to get rid of some of the wheezes. But more often than not, we're going to be giving it for asthma. So opening up those airways, that reactive airway disease. Precaution, again, history of high blood pressure, tachycardia, and they can't have any allergies to albuterol. Side effects, very similar to our Epi. They may have a cough because they've got gunk and gookies in their lungs. And what we're doing is we're opening it up. So now air is moving in the gunky and gookies and causing kind of a tickle, and they'll cough it out, which that's kind of what we want. We want that. We give it through a metered dose inhaler, which is just what we practiced before. This is what everybody carries around, inhaler. It really depends on the prescription. Typically it's 2.5 milligrams of albuterol, but it could be 1.25, it could be 3 milligrams. It really just depends. And if we give it nebulized, the stuff that the barrel was carrying for a while was 2.5 milligrams in a 3 ml solution. So that blue stuff on the side there, that's 3 milliliters of liquid in those little plastic vials, and there's 2.5 milligrams of medication in it. So that's what that means, 2.5 milligrams in a 3 ml solution. And typically to get it to nebulize, it's about 6 to 8 liters per minute. And that's what's going to make it all get all kind of smoky and hazy looking. Glucose. So it is a simple sugar, it's a carbohydrate, feeds the muscle, organ, tissue. This is what we need to basically feed our brain. Our brain needs this to function. We're going to give it for altered level of consciousness. If you suspect that they're diabetic and hypoglycemia, you're also that's also one of your indications for it. If they don't have the ability to protect their airway, yes, it's contraindication for oral glucose, but it's more of just a precaution because you give it buccally, or if you have to, if they've lost their airway, you will have to do it by another means, which means per rectum or rectal. Typically 12 to 15 grams depending on the manufacturer. Those are glucose tabs on the side there. They are 4 grams a piece. So 4, 8, 12, 16 or 12. So it really just depends on the brand that you get and the style that there is. Naloxone, Narcan is the brand. So naloxone is what it is. It's an opiate receptor agonist. What it's going to do is it's going to sit in little opiate receptors in your brain, so the opiate itself can't get in there and trigger that not wanting to breathe action of the drug. So altered level of consciousness. So you have somebody that's in and out of consciousness, or they're altered, they're not waking up. You can try giving them some glucose, you can try giving them some Narcan or naloxone and see if that wakes them up. If you suspect that it's an opiate overdose, definitely try your naloxone. Really, there's no indication or a contraindication for it. It can cause withdrawal symptoms. So little old Granny, she has some significant pain. She accidentally took a little bit too much of her fentanyl, and then you slam a bunch of Narcan in there, she could go from no pain to extreme pain very quickly. So that's more of a precaution. So be mindful of how much you're giving, what you're giving it for. Don't be just vicious about it. Everything used to be like 4 milligrams. A lot of them are now going to 8 milligrams. The box on there, the Cloxato, that's the other brand of the naloxone. So it's not just Narcan out there. There's other ones out there. If you do give it intranasally or IN, you give half the dose in one nostril, half the dose in the other nostril. So being quick enough to make it atomize, but not too quick to where you don't have the other nostril amount. Tylenol, we didn't really talk about this much. So acetaminophen's the actual name of it. Tylenol is the brand. It is an analgesic. It's also an antipyretic, so it decreases fever. It decreases the pain response. We're going to give it for fevers, for seizures caused by fevers, so febrile seizure, and you can also give it at the EMT1 level for pain with mild trauma when ALS person's not available. We want to be mindful of liver disease, allergies with our Tylenol. So it can cause anxiety, some fatigue. Yes, it can cause a headache, abdominal pain, mostly because when you take it on an empty stomach, it can cause all sorts of pain and cramping and nausea and stuff. So 15 milligrams per kilogram by mouth or PO, usually up to a max dose of 650, but it depends on the service. Some services go to 1,000 milligrams. So examples down below, if you give like the tablets, those tablets are 325 a piece. You give 2 of them for an adult, it's 650 milligrams by mouth, and that's how you'll document it. If you have a child that weighs 12 to 17 pounds, you're going to put it into kilograms. And on there, it's got 160 on the box. I'm looking at the box of the liquid for the children's Tylenol. 160 milligrams per 5 mLs. So it's a lot easier to kind of do it in like straight mLs. So you could do 2.5 mLs, which is going to be 80 milligrams, and it's going to fit within that 12 to 17 pound child dose. All right, patient management. So I've given you a bunch of different medical diseases and ailments. You've got information on the drugs that you can give, and how you're going to transport them. A lot of times it's going to be Fowlers or semi-Fowlers. You need to do your OPQRST. You want to know when it started, like what were they doing? Were they moving around? Were they resting? Did it come on suddenly? Did it gradually worsen? Did it wake them up out of a dead sleep? Provocation and palliation. What makes it better? What makes it worse? Is it worse when you breathe in? Is it worse when I touch it? Moving, walking around, exercise. Does it get worse if you are eating? Does it get worse if you're swallowing? Have you tried doing any antacids? Did that help it? Quality. What does it feel like? Is it local tenderness? Is it sharp, squeezing, dull, pressing, pressure, crampy, burning? Like, describe what it feels like. If they do not have a way to describe it, list a bunch of them out there that are kind of opposite. Radiation or region, where do you feel it? Where does it go? Is it localized? Like, is it more discomfort in one area and like just a dull achiness in a different area? Is it in your upper back? Is it in your jaw? Is it all over? Severity, how bad is it on a scale of 1 to 10? So like 0 is nothing, 1 is some little, oh, it's there, 10 is the worst. And then what time did the pain begin? 2 hours ago, 15 minutes ago, at 6 p.m., at 5:30, like it's specific on like the time or how long ago it was. So with all of these, so ACS, acute coronary syndrome, you're going to do your OPQRST. You're going to do your differential diagnosis. You want to make sure that this is cardiac. You're going to rule out trauma, that this isn't like a broken rib that's causing the chest pain. You want to get a temperature and listen to lung sounds and listen for that pneumonia. You're going to be feeling for that subcutaneous emphysema. You want to make sure that they're not having an anaphylactic reaction, that they're not having an asthma attack. So differential diagnosis, rule in and rule out. You want to know that this is ACS, that this is not something else. You're going to treat and maintain their ABCs. You're going to give appropriate oxygen. You're going to give your 0.04 milligrams of nitro as long as the vital signs and history account for that. And you're going to give your 81 milligram tablets, either 2 or 4 of them, chewed by mouth for your patient. And you guys are also going to be able to put up an EKG. For your respiratory, same thing, op course, and you're going to do your differential diagnosis. You want to rule out asthma, you want to rule out COPD, infection, allergies. So how you do the allergy is you start asking the other allergy questions. History of allergy. Were you exposed to this allergen? What about toxins or poisons? What did you take? How much of it did you take? Or an infection. Have you had any recent illness? Have you had any like fever and cough and those kind of things. Your COPD, like how long have you had this history? Are you on oxygen at home? You're going to treat and maintain their ABCs. You're going to provide oxygen, whether it's now a breather, CPAP, nasal cannula. Maybe you have to nebulize a medication. And you're going to give your meds. It could be epi, it could be albuterol, or oxygen itself being your medication of choice. Altered level of consciousness, doing your op course, but you also have to do your differential diagnosis. Do they have a stroke? Like, how long has this altered level of consciousness been? Has there been signs of like extreme thirst and urination and hunger? Have they had seizure-like activity? Have they eaten something that they shouldn't? Is there like burns around their lips from a caustic substance? Do they have effects on one side of the body? Like, so they're having left arm like weakness or paralysis. Do they have the ability to speak? Do they have slurring of their words? These are the different things you need to start looking for and asking for when it's altered level of consciousness. Regardless of that, once you figure out what it is, you're always going to treat ABCs, give oxygen as needed, and if there is a medication, we can give it. So we could give the naloxone if we think it's an overdose. We could give the glucose if we are thinking more of diabetes and hypoglycemia. All right, so we covered very, very quickly some medical terms. You guys are going to be able to look all those up. You can look at the reading material that's also going to be added to this. The medical diseases that you must know these. Coronary artery disease, endocarditis, heart attack. We've covered those. They're also in your reading. Different transport positions, how we're going to put them in the back of the ambulance, your medications and pharmacology. Know your rights, the right dose, the right patient, the right route, the right time, the right documentation. It cannot be expired. Has to be the patient's own medication for some of them. You have to do blood pressure and stuff before you give it. You have to know these medications. And if you guys do want to click on some of these, there's some good videos at YouTube one. They've got some pretty cool stuff in there about tension pneumothorax, diabetic ketoacidosis, if you want some more information on there. But definitely go to your reading, and I hope you guys enjoyed very quick hour-long presentation.